Welcome to The Explainer. Today, we're zeroing in on one of the absolute most fascinating structures in the human body. It's this tiny, temporary vessel that acts as a vital, life-saving bridge before we're born. But here's the catch. If this exact same vessel fails to close up after birth, that fetal lifeline suddenly transforms into a potentially fatal flaw. We call this condition patent ductus arteriosus, or PDA. So in this detailed breakdown, we are going to completely demystify PDA. We'll look at how it forms, how it malfunctions, and the incredible precision-driven surgery used to actually cure it. Let's dive in.
All right, here's our roadmap for today. We'll quickly cover 1. The basics of PDA, 2. A cardiac surgery milestone, 3. Anatomy of a defect, 4. Diagnosing the danger, and 5. Surgical repair techniques.
Okay, starting right off with Section 1, the basics of PDA.
So the really crucial thing to wrap your head around here is that before birth, this is a perfectly normal, absolutely essential structure. In the fetus, the ductus arteriosus connects the upper descending thoracic aorta right to the proximal part of the left pulmonary artery. You can kind of think of it like a temporary bypass road used during a massive construction project. But once the baby is born and takes that first breath of air, that bypass is supposed to shut down. If it stays open, or in medical terms, if it remains patent, it becomes a persistent and dangerous defect.
Now, how does the body normally handle this? Well, it's basically a 1-2 punch. First up is what we call functional closure. This is a quick, intense muscular squeeze that happens just hours after birth in full-term infants, where the smooth muscle in the ductal wall just clamps down. Then comes anatomic closure. Over the next 2 to 3 weeks, fibrous tissue actually grows in and permanently glues the passageway shut, turning the whole vessel into a solid band known as the ligamentum arteriosum. When this beautiful, complex process fails, that's when we're left with persistent patency.
Moving right along to Section 2, a cardiac surgery milestone. You know, historically speaking, this wasn't just another medical anomaly. It was literally the ultimate proving ground for heart surgeons. The ductus was actually first described way back in AD 129 by Galen. Fast forward all the way to 1888, and Monroe proved on an infant cadaver that surgically ligating or tying off the PDA was technically possible. But doing it on a living patient? That was incredibly risky. In 1937, Streeter made the very first surgical attempt on a patient with a severe infection, but sadly, it ended tragically. Then on August 26, 1938, everything changed. Dr. Gross successfully ligated the PDA of a 7-year-old girl. Successfully fixing this one single defect effectively gave birth to the entire field of modern pediatric cardiac surgery.
All right, Section 3, anatomy of a defect.
Let's look at the physical reality of this thing inside the chest. When you check out the 3D digital model on the left, it looks so clean, right? It neatly maps out a standard, isolated PDA connecting to the aorta just a few millimeters past the left subclavian artery. But then, look at the actual tissue specimen on the right. That shows the stark, totally organic reality of how this ductus so intimately connects the aorta and the pulmonary trunk. You can really see the thick, highly vascular nature of the tissue there, which makes it super obvious why surgeons need such insane precision when they go in to fix it.
And to put the anatomy into perspective, this data table is wild. It shows how the geometry of this vessel completely shifts if there are other conditions present. In your typical isolated PDA, you've got this really sharp acute proximal angle, averaging about 29 degrees where it meets the aorta. But look at what happens if you introduce another defect, like pulmonary atresia, where the pulmonary blood flow relies entirely on the ductus. The flow pattern from fetal life actually reverses, and because of that, the angle totally flips to an obtuse 83 degrees. This massive shift in geometry makes navigating and repairing that area incredibly tricky for a surgeon.
Next up, Section 4, diagnosing the danger.
So what does this defect actually do to a patient? Well, it depends entirely on the size of the hole, which determines how much blood shuns from left to right. A large defect? That is bad news. The pressures between the aorta and pulmonary artery equalize, and as the newborn's pulmonary resistance drops, blood just floods the lungs. We're talking rapid, severe heart failure, poor feeding, and a forcefully thrusting pulse. If nobody treats it, it can even progress to Eisenmenger syndrome, permanently scarring the lung vessels and causing severe oxygen deprivation. Now, a moderate PDA typically shows up as subnormal physical growth, a jerky pulse, and a really loud, continuous murmur. But a small PDA? It might just stay completely hidden in early life, with absolutely zero symptoms, aside from a tiny, short murmur that takes a very sharp ear to catch.
Speaking of that murmur, just listen to this quote from Gibson back in 1900. It's almost poetic, isn't it? But it flawlessly captures the famous machinery murmur of a moderate PDA. It's this rough, thrilling sound that completely defines the diagnosis in a clinical setting. It actually masks the normal heart sounds, rising and falling with every single heartbeat, usually at its loudest right over the pulmonary artery. It's literally the audio signature of a heart working overtime against a massive, abnormal pressure leak.
Finally, Section 5, Surgical Repair Techniques. Okay, we're taking you straight into the OR now. These are the incredibly precise, choreographed steps a surgeon takes to actually reach the heart. First, the patient is placed on their right side. The surgeon makes a posterolateral thoracotomy, basically an incision on the side and back of the chest. They meticulously count down to the exact right rib, enter the chest cavity, gently retract the lung out of the way, and then begin the painstaking process of dissecting the PDA away from all that surrounding tissue.
So, it all starts right here. You can see this carefully mapped out, curving skin incision line. It's positioned just 1 to 2 centimeters below the tip of the scapula. Depending on how old the patient is, this specific incision targets the exact intercostal spaces, the spaces between the ribs, needed to get the very best exposure of the left side of the heart. Once we're inside, a specialized rib retractor is cranked open, nice and gradual. The left lung gets gently pushed aside and held safe with moist gauze. Then, they make a vertical cut right over the mediastinal pleura. That's the membrane covering the area, and pull it back with traction sutures. And boom, right there, the great vessels of the heart are perfectly revealed.
Now, once it's fully exposed, the surgeon has to make a big call: division or ligation. Basically, do we cut it or do we tie it off? Ligation means they just tie off the pliable ductus super tightly using a heavy-duty suture on both ends without cutting it. Division, on the other hand, means completely severing the vessel in half and very carefully stitching the stumps shut. They usually go with division if the ductus is larger or a bit more complex.
Just look at the extreme level of care happening here during the dissection. The surgeon is elevating these incredibly delicate connective tissues that surround the heart. They have to free up the ductus without disturbing the left recurrent laryngeal nerve, which is hiding directly behind it. Literally, one minor slip here could permanently paralyze the patient's vocal cord. Talk about high stakes, right?
Now, if they're doing a surgical division, the surgeon carefully places these specialized angled clamps to completely stop the blood flow. One goes on the aortic end, one on the pulmonary end. And the technique here is fascinating. They actually try to squeeze the clamps down onto the adjacent arteries a bit to stretch the ductus out. That ensures they leave a really safe, substantial cuff of tissue sitting right there between the clamps.
And this, right here, this is the true moment of release. Using Pott's scissors, or sometimes a scalpel, they just slice that abnormal connection right down the middle. This physically, permanently separates the systemic and pulmonary systems, instantly curing that massive pressure leak that had been straining the poor patient's heart. To finish the whole thing off, both of those newly severed ends have to be locked down tight. They oversew them with 2 rows of a super precise whip stitch. They'll also pop a little pledget of absorbable gelatin sponge right in between the ends, just so the fresh sutures don't rub against each other. When they finally release the clamps, they watch closely. There should be absolutely zero bleeding. And just like that, the repair is complete.
I want to leave you with this final kind of mind-blowing thought. By conquering this one tiny malfunctioning vessel back in 1938, those early surgeons proved something revolutionary, that the human heart wasn't untouchable. They proved it could actually be operated on and fixed. This one single procedure absolutely shattered the myth that the heart was off-limits to a scalpel, and it threw open the doors for the entire modern era of life-saving open-heart surgeries that we all rely on today. Thank you so much for hanging out with me for this explainer. I really hope you're walking away with a brand new appreciation for the absolute mechanical genius of the human heart.